The initial data was presented in AACR in April of 2019 by Dr. Pearl, and it compared patients with FLT3 positive disease, either the ITD or the TKD mutation, and so patients were randomized in a 2-to-1 fashion to either gilteritinib alone versus chemotherapy, and those patients were allowed to go on to transplant, and if they were randomized to the gilteritinib arm, they were also allowed to get maintenance gilteritinib afterwards. And we saw that response rates in patients with FLT3 mutations were actually double compared to chemotherapy alone. And I think the implication of this is, again, we have an oral targeted therapy, so it's obviously more effective as proven. It's going to be less toxic because it's targeted. The big thing is the patients that went on to get transplant, they were treated with a therapy that wasn't as toxic, so they weren't as quote unquote beat up going into transplant, so they were able to tolerate the transplant better and have an option for maintenance therapy to prevent relapse after transplant, which is a real concern for patients that have this aggressive FLT3 mutation.